Recording in progress.
Good evening, everyone. Firstly, it's a pleasure to have one more session on recent advances. So, as you all know, we are running a series on recent advances, and today we have a very eminent speaker, a teacher par excellence, Dr. Sandeep Grover from PGI Chandigarh. Welcome to you, sir. And thanks for accepting our invite.
Thank you, Anil. It's my pleasure.
And we have two very eminent chairpersons to chair the session. Dr. Shaji from Thrissur. Welcome you, sir. And Dr. Sujit Sarkil, our publication committee co-member from Kolkata. Thank you. I welcome Dr. Deepayan, also our publication committee secretary. And we expect our IPS Vice President Vinay Kumar to join soon. So today we have a very important topic on delirium and recent advances in the assessment and management of delirium. A very important topic for postgraduates, for practicing psychiatrists, as delirium is probably one of the most commonest reference we get in a consultation liaison kind of setting. So to start with, I can introduce the speakers, introduce the chairpersons. We have a very eminent chairperson, Dr. K.S. Shaji, who is one of the teacher of teachers and currently the Dean of Research at Kerala University in Thrissur. He needs no introduction to this audience, but however, he has a vast experience and his research capacity building experience. He has experience in scientific writing, a very well-known researcher in geriatric mental health and on public mental health. Sir has received very eminent awards. Dr. Vimla Vimani Award in 2009 from the National Academy of Medical Sciences. Professor Surinder Mohan Marwa Award in 2008 from the ICMR and the ICMR International Fellowship for Senior Biomedical Scientists in 2012. So, sir has experience for several decades on, especially in dementia and issues related to geriatric mental health. So, we are happy to have you, sir. Thank you. Next, we have Dr. Sujit Sarkil. So, he is currently the Associate Professor at Institute of Psychiatry, Kolkata. He is currently the editor of Bengal Journal of Psychiatry, Associate Editor of Indian Journal of Psychiatry, Assistant Editor of Indian Journal of Psychological Medicine and Indian Journal of Private Psychiatry. Dr. Sujit, a very good friend of mine, has more than 60 publications and is one of the members of the publication committee. I welcome Dr. Sujit.
Thank you. Thank you.
Both the chairpersons, I request Dr. Deepayan to give some introduction to the topic.
Thank you, sir. A very good evening to everyone. And I can see that, that today we have this third series of our webinar. Earlier we conducted two webinars, and I hope it was the today's event that we kept. That title it goes like that: recent advances in the assessment and management of delirium. And we have seen that in our practice also, and in our hospitals, in clinical setups, we need to see many patients of those who are having a delirium or delirious condition. In these conditions, actually, we need to, as well as we need to rule out medical conditions, and we need to guide the patient parties in numerous times that how to get the proper treatment. And sometimes the cause of delirium to find out also is difficult, and it is very much confusing. So I think today's this webinar, it is very much pertinent, and the speaker we have today, he is very knowledgeable, and all of us, we know him very well. And I hope in the following slides and in the discussion today's evening, and all of us will be very much enlightened with his knowledge and his experience. So this is from my side, the submission, and I request Dr. Vinay Kumar sir, if he is there, just to give some introductory comments.
Dr. Vinay will join shortly. I request Dr. Sujit to introduce the speaker.
Yes. While Vinay sir takes some time to join, I would take the pleasure to introduce Dr. Sandeep Grover, a speaker, a very beloved senior. Often we work together for the journals, and I think, the number of publications and citations, if you go by, it is, insurmountable. Currently, he is working as the professor of PGI Chandigarh, and his areas of interest, consultation liaison psychiatry, obviously, and that is why he has got major publications in the areas of delirium, which makes him really a suitable speaker for today's program. Apart from that, areas are geriatric psychiatry, severe mental disorders, and psychopharmacology. He has more than 800 publications, more than 80 book chapters. And apart from that, he is an editor of several journals, namely in the geriatric mental health and also the North Zone Journal and also the SARC Psychiatric Federation, and associate editor of IJP since 2009, Indian Journal of Psychological Medicine, Psychosexual Health, and IJPP. And he has more than 60, around 65 awards to his credit. So I think here is a multifaceted psychiatrist with many areas of interest, but definitely if we have to take one or two major areas, delirium defines that. And it would be a treat to listen to him speak on this area for which he has worked for so many years. Over to Dr. Grover to carry forward.
I just request Dr. Shaji to give some his remarks on the topic before we hand over to the speaker.
Yes.
Thanks, Anil. And I think it is a pleasure to listen to Sandeep. And I'm sure this is one of his favorite topics. He has done tremendous work on this. So we will now listen to this topic, that is recent advances in the assessment and management of delirium. It's very obvious that we should identify delirium very early. But then once you identify delirium, then you enter into a process of continuous assessment and continuous management. I personally believe that assessment and management goes hand in hand, and depending on the current assessment, you might want to change the management, and it's a very, very dynamic situation. So I'm sure Sandeep will tell us much more about the recent advances in the management as well as assessment. Over to you, Anil and Sandeep.
Yeah, the floor is open to Dr. Grover.
Yeah. Thank you, Dr. Anil and the whole publication committee. I hope I am audible.
Yes,
very much.
Yeah. So today I'm just going to discuss about the recent advances in assessment and management of delirium. If I disappoint anybody on talking about the basics, I may not be touching the basics too much. I'll be talking about what is happening in the last 10 years, although I'll be giving you some idea about what are the basics. So when I'm presenting this topic, I do not have any conflict of interest to disclose, except that I have an interest in this area. And in terms of disclosures, I'll be using some of the images available on the internet to convey the message which I want to, but the copyright of the images are with the original author. So I do not claim any copyright for those images. And wherever it has been possible, I have provided the adequate reference to the same. So without wasting much time, let's try to understand delirium. There are certain basic things which we as psychiatrists need to understand. The delirium is a complex neuropsychiatric syndrome, and which occurs due to either a structural or the physiological abnormality that directly or indirectly affects the brain. And it is understood as something like an acute brain failure. We all as physicians or the clinicians understand that liver failure, renal failure, hepatic failure, and so on, or the cardiac failure, but we never talk about the brain failure. So as psychiatrists, I feel somewhere we often fail to communicate to our colleagues that we are dealing with an acute brain failure. Similarly, dementia can be understood as a chronic brain failure. So if you remember this, this often helps you to communicate with your colleagues that this is an acute brain failure condition which is arising because of failure on the other organs like renal failure, hepatic failure, or the cardiac failure. That's a simpler way to understand it. And as we understand other failures as acute or chronic, so acute insult is always or mostly in any organ is usually reversible, and same is true for dementia, delirium. And again, as we understand, because we are talking about acute failure, so it has an acute onset and the typical fluctuating course. And earlier it was believed that it is more often, or it is seen only in elderly, but now that myth has been broken, delirium is seen across all age group. So these are the certain basic facts which we need to remember. And as some of my colleagues have already alluded, it is possibly the most common psychiatric morbidity seen in patients with acute medical illnesses where we are called as a consultation licensed psychiatrist. And the important fact to remember that it is seen across different settings, from emergency to medical ward to the surgical ward to the ICU, or let's say to the outpatient setting. And among all the psychiatric disorders, delirium is the only condition which is purely organic in etiology. For example, when we talk about psychosis or affective disorder, we can talk about organic versus functional. Although I know that people may question why when I say organic versus functional, but for delirium, I just want to highlight it is the condition which has only organic etiology and there is no functional equivalent of delirium. And the unfortunate thing, which is that it is often misdiagnosed or it is not detected, and often the psychiatrists are not called by the clinician and themselves try to manage, or they don't manage. And as a result, this is often under-recognized and under-treated. And when we look at how common it is in terms of prevalence, you can see that the prevalence actually depends on the setting in which we are evaluating a patient of delirium. In general, the prevalence rates are higher as you see patient with more severe physical illnesses. For example, in ICU, the prevalence rate in adult may go as high as 60%, and those in elderly may go as high as 83%. And when we talk about the people who are suffering from malignancy and others, especially the elderly, the prevalence rate may be again about 85%. However, if you want to just remember one figure for the elderly, 75% of the elderly who undergo surgery will have, or suffering from a medical illness will have delirium at some point. So every 3 in 4 are going to have delirium when they have a medical or surgical decompensation, especially the elderly. What are the consequences of delirium? Because this is very, very important. Why are we talking about? Because delirium is associated with high risk of mortality, and not only in medical surgical patient also, but in the ICU patient. It has been seen that even though we control for other factors, still the mortality rates are much higher, and mortality occurs during the first month, which is much, much higher. And but by 6 months, also the mortality rates have been found to be higher, and it is reported to be 3 times more than what is in those who have not developed delirium. And the newer insights which we are developing now, that is, it is associated with higher risk of cognitive impairment, and it is considered as a precursor of dementia. It increases the hospital stay, and it also increases the cost of treatment, and also leads to higher risk. It is associated with higher risk of getting admitted to a nursing home. So if you just want to remember the whole consequences of delirium, just remember the 6 Ds. That is, delirium is associated with increased distress to the patient and the family members, increased rate of death, increased duration of the hospital stay, higher cost, higher risk of dementia, and it often leads to a lot of dignity loss to the patient. Now, coming to the world recent advances. So for this talk, I've just tried to look at the research which is emerging in last about a decade or so with this background. Now we'll move forward with this small background about what do we understand by delirium. So if we look at the areas of main research, well, what we need to understand, for this talk, I've tried to divide it into certain specific areas. Nothing very particular about it, why I've decided, but I thought that that's how I can organize the talk. And when we look at the nosology, what is going on in the area of delirium? If you look at these are the ICD and DSM-4 criteria, the primary criteria here was disturbance in the consciousness and attention, and the global dysfunction in the cognition. And if you look at the ICD-10, there are other criteria which have been talked about, but in DSM, just they talk about it develops over a short period of time rather than specifying the acute onset. And when we look at the primary criteria of altered consciousness and attention, both the diagnostic system talk about basically about the continuum from clouding of consciousness to the coma, and talk about the disturbance in the level of attention. And in terms of global dysfunction of cognition, again, there are some differences between the two systems, but they basically again emphasize on the disturbance in other cognitive function. So here you need to understand, when they talk about global dysfunction in cognition, it also includes what we understand as perceptual disturbances, or to certain extent delirium, delusions also are included under the same domain of global dysfunction of cognition in the ICD-10, whereas DSM-4 talks about cognition in the perceptual disturbances. One of the major problem was when we look at the ICD-10 and the DSM-4, what we found that before people move forward to DSM-5 and ICD-11, the major areas which were of confusion was lack of clarity between the boundary of stupor, coma on one side and delirium. So we always got confused that can we diagnose delirium in a patient who is stuporose or comatose? And that was an issue among the researchers, and they were very confused about this fact, and that was often leading to overdiagnosis or underdiagnosis of delirium, because whatever approach you as clinician will take, that will determine the prevalence or the incidence of delirium. Again, the issue of diagnosing delirium in patient of dementia had a confusion whether somebody has dementia, so can you diagnose him with delirium or not? There was some confusion, although people were diagnosing that on their own means, and there was no clarity about that how to or when to take the cutoff. So keeping this in mind, the DSM-5 and the ICD-11 moved forward, and they, rather than talking about consciousness, they gave more importance to the attention and awareness. The awareness domain basically means the orientation or disorientation. So if you look at the primary criteria now in DSM-5 and ICD-11, again, they talk about attention and awareness. So if you look at the attention and awareness criteria, they basically talk about different subtypes of attention or the disorientation. And in terms of disturbance in cognition, again, they talk about other cognitive disturbances, including, but here they talk about perceptual disturbances. Also, they do not talk about something like a delusion. So that's a major change if you try to understand that. And again, if you look at DSM-5 has persisted with development over the short period of time, and it should not be explained by the pre-existing, established or evolving neurocognitive disorder. Means that gives you an idea that where you can go ahead. So you have to take whatever at level a person of dementia is performing, and if he has developed cognitive disturbance over and above that, then you can consider a diagnosis of delirium in patients of dementia. That's the clarification which the DSM-5 has tried to provide. ICD-11 has again almost continued with the other kind of description which earlier it had. So that's a major change. If you try to look at the nosology, we have now dropped the word consciousness from the diagnosis. So that's the first, I want all of you to make a note of it. Now, let's move to the pathogenesis of delirium. So how do we understand this? So we have been understanding this over the periods as predisposing factors and the precipitating factors, but now we are moving a step beyond that to understanding what are the biomarkers of delirium. Either biomarkers here do not necessarily mean that they will be able to explain the etiology, but they'll be able to help us in understanding how it influences the outcome of delirium. And we have developed different hypotheses why somebody develops delirium. So let's try to have a look at this. We all know that there are a lot of predisposing factors for delirium, but now we are trying to have an understanding about this from a perspective that which can be modifiable and which are not modifiable. It's again in the same line as we are talking about dementia. So what are unmodifiable factors, what are potentially modifiable factors, and the modifiable factors. So the whole the so-called importance in the management or the assessment is look for the potentially modifiable factors or the modifiable factors. And just for your remembrance, if you just want to remember what is the short list of predisposing factors, so any kind of sensory impairment, use of over-the-counter medication, more severe the illness, poor functional ability, somebody who's elderly, who is having cognitive decline or dementia, and who is on a lot of prescription medication, has a lot of comorbid physical illnesses, alcohol use, and male. So it's a combination of predisposing factors if you just want to remember the mnemonic, because CAM, you will understand why I've used this mnemonic here. In terms of precipitating factor, this is something like which triggers the development of delirium. We know this mnemonic which has been used in the delirium literature for long, that eye watch death, which includes certain acute toxic kind of situations, which include infection, substance withdrawal, metabolic disturbances, trauma, or any CNS pathology, hypoxic injury, or nutritional deficiency, endocrinopathies, and any vascular insult or any kind of toxins. So this is what we understand as precipitating factor. We need to understand the difference between precipitating factor and the predisposing factor. Maybe I'll clarify that slightly later. And if you just want to again remember a small mnemonic, how to remember the precipitating factor, you can remember the mnemonic as delirium per se, which includes the drugs, electrolyte imbalance, lack of drugs, that is a withdrawal, infection, reduced sensory inputs, intracranial pathology, urinary retention or fecal impaction, and the myocardial or the pulmonary decompensation. And in terms of the drugs, again, the simpler mnemonic to remember is the acute change in the mental state. So different class of drugs which are primarily associated with delirium. But now we have gone a step beyond this, and we have now started understanding it's not the class of the drugs which matters, but it is there the anticholinergic property of the drugs, how much is the anticholinergic activity which each drug carries. And we have developed now the scoring system for anticholinergic activities, like some of the drugs are given an anticholinergic score of 1, 2, or 3. And those who have score of 2 or 3 have high anticholinergic properties. So they are more likely to cause delirium. So when you are going and checking a patient's prescription, maybe at the bedside, you can calculate the anticholinergic burden by using online calculators now, and you can decide which one to taper off, or you can check each drug which the patient is receiving, and you can decide which one you want to stop. As I said, that what is the relationship between the so-called precipitating factor and the predisposing factor? So what we now understand, it's a balance between the two which determines when a person is going to develop delirium. And those who have higher vulnerability may require lower precipitating factor. For example, in an elderly who has multiple physical illness, he may develop delirium at a sodium level of 132. Or whereas a young man who doesn't have much of physical illnesses, just had some fever, although he's having sodium level of 124, doesn't develop delirium. So it's a combination and a balance which determines when a person is going to go on to develop delirium or not. So if you have higher vulnerability, you require less noxious insult. And when you have the lower vulnerability, you require the more noxious insult. So that's how the relationship has now been understood. And now we totally understand, like in the COVID era, a lot of things came in. So all the factors have been now grouped as so-called premorbid factors or the predisposing factors which are related to the presenting illness, and the post-admission factors, so that the hospital-related factors can be taken into account. Then we are now trying to understand various biomarkers for delirium. And these biomarkers are not necessarily trying to give us an understanding about the etiology, but we're just trying to see which all serum and CSF markers are increased or decreased in patients of delirium. And you can see here that there are a lot of things, the different kind of acute stress reaction markers or the inflammatory markers which have been seen to be increased, and we have good evidence for that. And one of the important biomarker which is emerging is the systemic inflammation and the astrocyte and glial activation marker, that is S100 beta. And that has been shown now to be associated with longer duration of delirium, higher severity of delirium, and higher hospital mortality and from the delirium. So if you are regularly monitoring this in your patient, you can possibly predict what would be the outcome of the patient, or how do you want to monitor your treatment in future maybe. And other parameters like the interleukin 6, 8, and the plasminogen activating inhibitors have been shown in the emergency department to be associated with prolonged delirium in patients who do not have dementia. So these are certain things which are emerging now. Maybe in the due course of time, we'll have much better understanding about this. And in terms of the etiology, if we try to understand why some people that we have multiple etiologies for delirium, but the manifestations are same. So the basic thing here, we have now understand that it is basically due to the neurotransmitters, that is the reduction in the acetylcholine levels and increase in the dopamine levels. That was the earlier understanding, but now things are changing, and we understand it's not the acetylcholine and dopamine which acts in isolation, but they are also interlinked to other neurotransmitters, and it's the balance between these two transmitters and the glutamate, GABA, and the opioids which determine the development of delirium and plays an important role in the pathogenesis. And now more and more hormones and the neurotransmitters are being implicated here. And if you again try to understand why it happens, again, different etiological pathway causes or work through the different pathways, like including the GABA, glutamate, or the steroidal pathway, or the serotonin deficiency, or the activation pathways. So what basically we have developed now is about 7 to 8 hypotheses why somebody develops delirium. And some of these hypotheses, again, take both precipitating factor and the predisposing factor into account for us to understand why somebody is developing delirium or somebody who is more vulnerable to delirium. So when we look at the neuronal aging and the circadian rhythm dysregulation, we now are understanding that with neuronal aging, the ability of the neurons to reach to a homeostasis is reduced. They are not able to adapt much. So when they are exposed to the lower level of stimulus also, that leads to delirium. And similarly, the circadian rhythm, again, in elderly gets disrupted. And also those who are hospitalized, when you are in not your normal sleeping conditions, your circadian rhythm will get disturbed. You will not be able to sleep. So that leads to development delirium. Similarly, in the neuroinflammation, because of the infection, others have been studied, and oxidative stress, again, because of the inflammation. And similarly, the stress pathways come in whenever somebody has infection or any acute physical illness also. So that's the neuroendocrine pathways have been talked about here. And all this contribute to the network disconnectivity and the neurotransmitter dysregulation, and that leads to the acute brain failure. And this has been further refined, this whole pathogenic mechanism is further defined, that whenever we have a precipitating factor, depending on the vulnerability, that is these are the substrates, that the aging, inflammation, oxidative stress, endocrine disturbances, and the circadian dysregulation, these will interact with each other and also with the precipitating factor and give rise to the neurotransmitter dysregulation and lead to network disconnectivity between the different areas of brain. And that will ultimately lead to what is now known as the system integration failure. So that is where, when the system integration failure occurs in the brain, you see a patient with acute brain failure, or what we understand as delirium. With this, now let's move to, can we predict delirium? Because we all are talking about the prevention of delirium, and this is because we all understand it's a lot of negative consequences. So people are now making efforts to understand how we can predict delirium. So in one of the recent research, people have tried to take certain factors. They have included 10 risk factors to understand that whether we can predict somebody is going to develop delirium in future or not. So these factors are used in a different permutation combination. The statistical models have been developed. And what does this model suggest? That if you use these 10 predictors or the risk factors, your prediction that somebody is going to develop delirium in due course of time is much better than what any clinician or physician can predict. So that is where we are now developing these kind of models to understand the prediction of delirium, so that any ICU patient or any medical surgical ward patient can be screened beforehand to understand whether he's going to go on to develop delirium or not, so that resources can be mobilized so that he or she can be given more attention and we can prevent an episode of delirium. And similarly, we have developed a prediction model for alcohol withdrawal severity. And again, it is a 10, so the 10-point scoring, where we have 10 questions which a person is supposed to answer. If he or she is scoring more than 4, he is at a higher risk of developing delirium or the DT. So this is where, when you are seeing a patient of delirium, patient coming with alcohol withdrawal, and you want to see whether he or she is going to go on to develop DT or not, you can use this kind of a model to predict whether the chances of developing delirium is there or not. Now, coming to the basic thing, which is the assessment in various settings. So what has been the primary focus of assessment in patients of delirium? It is the screening, because the delirium is mostly seen in patients with acute medical surgical illnesses or the ICUs. The basic aim over the years have been to training them or making them aware about this condition and helping them to screen their patient for delirium. And the initial effort was in this direction. However, over the years, we have now moved forward to understand other different aspects of delirium. And this is a short list which we use commonly in delirium research or in routine clinical practice to understand what could be the outcome of delirium, or what we need to understand, what are the factors which are causing delirium, and so on. So when we look at this, we have different instruments for assessment of arousability or the premorbid cognitive status, this screening instrument, the diagnostic instrument, or for assessing the severity or the assessment of cognitive symptoms, the motor symptoms, the etiology, risk factor, and so on. And we have certain scales for assessing the delirium in children and so on. So that's how the things have move forward. And then we are now developing instruments. We are combining instruments like which are used to assess the severity of the physical illness, and we can predict the mortality. So over the years, the whole delirium research is moving to a direction where we can use multiple things to have understanding. But coming to the basic instrument, again, still the focus is on the screening. So the suitability for monitoring and screening is this basic column. So we need to understand that these are the things which are more commonly used. And among this, the CAM ICU, and DRS. These are the more commonly used instruments in delirium research or delirium clinical practice. Now, although the 480 is catching up, which I'll be discussing a bit in the next few slides. So the CAM is something which is the most commonly used screening instrument, which was designed in 1990s. And this can be used by anybody to screen a patient for delirium, and it usually requires 2 to 3 minutes to assess the patient for delirium. And basically, if the patient has three major findings, that is the acute change in the mental state, there's fluctuation in the symptoms over time, and patient has inattention, then you can consider the patient having delirium if he has first three criteria and one among the 4 or 5. And the information can be collected from the patient, family members, or the caregivers. So not necessarily that it totally depends on the assessment of the patient. Now, the CAM has been extended further because the delirium, there was always an issue about CAM that it was just a screening instrument. It doesn't give any severity. So now we have developed severity scores for the CAM, and the first 4 items of the CAM have been incorporated in the longer scale, which is a long CAM scale, and in which you have now the 10 items, and you can rate the whole severity of delirium, and it assesses various other aspects of delirium too. So we have now the extended CAM scale. And the other commonly used scale, which I said, is the acute 480, which was developed in 2011 in the UK. Again, designed to be used by any health professional. Initially, it was considered as a screening test, but later it has been named as the assessment test for delirium and the cognitive impairment. Again, it basically focuses on alertness, disturbed attention, the cognitive impairment, and the acute change. And if you try to compare these two scales, you can see that acute change and fluctuating course, which is at number 4 here, again, you see the similar kind of item. The first 2 are covered in one item here itself, and inattention is present in both. And whereas the CAM ICU does not assess orientation, whereas AMT4, that is which assesses the other cognitive function, is part of the 480. So you have a better assessment of both attention and the arousability. So in that way, the 480 may be slightly more broader scale than the CAM, which we have been using for over the years. And for the CAM ICU, again, we all know that the first step to assess is the level of consciousness or the arousability. So basically, if a patient has RASS score of -4 or -5, you cannot do the assessment for delirium. So that is where, while consciousness has gone out of the definition of delirium, you can understand this, that somebody who do not respond to the voice, you will possibly not assess them for delirium. So somebody who's just responding to pain or touch may not be a suitable candidate for assessment of delirium. And again, it also has the similar items as you see in the CAM, but here it is more structured and the questions are provided. And again, as in line with CAM, the CAM ICU severity grading has also been now developed. So we have scoring for the CAM ICU, and depending on how you perform, so somebody who's scoring between 3 to 5 may have moderate delirium, and somebody who's scoring 6 to 7 may have severe delirium. That's how the rating scales are now evolving. Now, the other issue in the area of delirium research is the subtyping of delirium. So we have been always talking about the various subtypes of delirium over the years. We have talked so many things, but we never settled down into a subtyping. So the most commonly accepted subtyping was the hyperactive, hypoactive is a mixed one. And till these 2007-8, we never had a specific scale to assess this, the motor subtypes of delirium, and we were using items from some other scale or some of the items, or with just the clinicians rating, understanding about whatever they want to call it as hyperactive or hypoactive. But in the year 2008, a scale of assessment for motor symptoms was developed by the David Maher group, and what they developed was a scale which has about 11 items, 4 for the hyperactive, 7 for the hypoactive. So anybody who meets certain, at least 2 criteria out of the 4 for hyperactive, and in the hypoactive, if you need to have 2 or more beside the first one here. And if you do not meet either, you will have no motor subtype, and if you meet both, you will have the mixed motor subtype, and the assessment period is the previous 24 hours. So that is where the first time a scale was developed specifically to assess the motor subtypes of delirium in 2008. They further, we worked with them together, and we try to replicate this so-called DMSS in our setting, and that led to certain amendments actually in the original scale. And now this is the amended scale, which was based on the combined data of our center and that by the David Maher group. And then we again worked, the David Maher, I was part of this group again, that we worked on developing an abbreviated scale, which is known as DMSS-4, which just has 4 items, and based on the different rating, you can decide about the motor subtype. Again, the other criteria remain same as 24 hours and so on. So we will try to concise the instrument as small as possible so that it becomes more easier for clinicians to use it in routinely, because the original scale had about 30 items. And various subtypes are now being studied also by using like the newer technology, the accelerometer and the sleep parameters. And we are just getting that some data, and the DMSS has been shown to do very well with the accelerometer data also. So this is some technology now which is entering into the delirium research as it is entering into the other aspects of psychiatry. The other features in terms of subtyping, which again, earlier there were few case reports, but this was the first study, first major study I can say in the world where we talked about the catatonic features in patients of delirium. And what we showed that as per Bush-Francis catatonia screening instrument, about 1/3 of the patients have catatonic features when they're developing delirium. And if we use by the DSM-5 criteria of delirium, the catatonia, about 1/8 had features of catatonia. And now other groups have started working in this area, and everybody is agreeing to our findings. And now people have started talking about catatonic type or a separate type of delirium where you see both features of catatonia and that of delirium. So that's where the whole direction is now moving forward to. Now, the other aspect which has been talked much in the was not talked much in the literature was the experience of the patients and caregivers once they go through the delirium. What is the whole experience of the patient? So the various studies across the world have talked about the issues about the pain, delusion, hallucinations. These are the basic experiences which the patient is going to experience. But we talked more about, in our studies, we have talked more about the psychological distress in patients of delirium and their caregivers, and we have evaluated the distress in the patients, those who remember their experience and those who do not remember their experience. And similarly, we have also evaluated the distress in the caregivers, how they deal with the distress when they are seeing their family member in delirium who is agitated, violent, aggressive, moving here and there. So how do they feel about that? And the next step, which we now have recently done, is that we have evaluated once the patient improves from delirium, we have evaluated the prevalence of PTSD in that, and PTSD rates are also quite high in patients of delirium. So we need to understand that delirium is not just a short-lasting illness, it has a lot of long-term consequences. Now coming to the final part about the so-called management part. So what we understand that the basic management of delirium depends on the addressing the acute cause, using the non-pharmacological measures and the pharmacological measures. If non-pharmacological measures remain the primary mode of treatment, and what we need to understand that in delirium research, We do not talk about prevention and management separately, basically because there is a lot of overlap between both pharmacological measures and the non-pharmacological measures when you're talking about the delirium. So over the years, what we have learned that the antipsychotics do not have much of role in management of delirium, or you use it in patients who have severe disturbances. Otherwise, the non-pharmacological measures like normalizing sleep, reorientation cues, relaxation techniques, they're educating the patient and the family members about delirium, encouraging the activity, mobility, pain relief. These are the things which have come up very clearly that these are more important than just writing an antipsychotic. So just correcting something like a visual or hearing impairment, those are more things which help. But if you look at what has changed in this area in last 1 decade. So earlier, there was a lot of emphasis on patient going to ICU to be sedated and given analgesics, and they should lie down. But gradually it has been learned that use of benzodiazepines and the opioids for sedation and pain actually leads to worsening of delirium, and they actually lead to more higher incidence of delirium, and as a result, poor outcome. So in this direction, some people have started, initially people started with some kind of quality improvement studies where they try to modify the sedation and the delirium protocols, and also the pain management protocols. And what was seen that the number of days, if you change the sedation protocol, the number of days without delirium gradually started increasing in patients with ICU. So this is where it led to it has led to major change in the ICU practices over the years. So now moving to the other important aspect is the post-operative care, because most of the delirium occurs in the post-operative period. So here again, a lot of research is occurring in understanding identifying the risk factors and how we can manage. And over the years, the emphasis is to shifting the type of anesthesia and the level of anesthesia. Can we do any change in that so that the post-operative delirium rates can be reduced? So here, people have tried to assess the association of the level of deep anesthesia and the development of delirium. And what has been done is it's been done basically by using the bispectral index, that is an EEG parameter, which gives you the hypnotic effect of various anesthetics. Different trials have been done. So basically at present, most of the trials have said that the so-called level of anesthesia is not making a major difference. So light or deep versus anesthesia is not making much of difference to the outcome of surgery. So major trials have been done in last decade or so. The other programs which have been developed are in the patients who are elderly, those who are in the elderly homes and other things. So here we have developed different programs to help the patient so that we can prevent delirium and at the same time possibly treat delirium, because there is a lot of overlap between the non-pharmacological measures. So one of the program is the HELP program, which includes that if there are elderly who have not developed delirium, but if they have risk factors, we need to do cognitive reorientation, provide them social support, manage their sleep, take care of their nutrition, mobilize them, and educate the healthcare workers to take care of them. So this is basically the healthcare program. This was basically developed in Boston by the Sharon Enoy group, and that is where this program has been evaluated in different studies. A meta-analysis of 14 studies shows that if you practice the HELP component, there's significant reduction in the delirium incidence, risk of falls, and the healthcare cost. And additionally, there is there's a trend toward decreasing the length of stay and preventing institutionalization in patients who are at a risk of developing delirium. So this program has got a lot of support in the elderly homes in US and UK. And now we are also developing programs for the ICU. So one of the initial program which was talked about was the ABCDE bundle, where we talk about awakening, breathing, so that the spontaneous breathing can be checked every day, the choice of sedation and analgesia which we give to the patient, screen the patient for delirium every day, and early mobility and exercises. This was the ABCDE program which was discussed for the ICU patient, and later this was extended further to ABCDF program. And here basically the ABCDE and ABCDEF, basically we have now started understanding that there's a interrelationship between the delirium pain and agitation and unpleasant awareness. So we need to tackle them very carefully. So we need to have adequate pain management and also manage agitation, so-called the sedation. So, but we are not supposed to overdo it, because if we overdo anything of this, both of these lead to development of delirium. So the ABCDEF bundle was created in 2014, basically focuses on pain, sedation, and delirium, uses validated instrument to assess all the three, defines significant pain and everything, provides specific recommendation how we can manage and prevent pain, agitation, and others, and talks about how we can, these are linked to the spontaneous awakening trials and the spontaneous breathing trials, and how we can engage the families. So the ABCDEF basically aims to optimize the pain management, break the cycle of deep sedation and prolonged mechanical ventilation, to reduce the incidence of and duration of ICU delirium, to improve the short and long-term ICU patients' outcome and reduce the healthcare cost. So if you just want to understand the ABCDEF bundle, basically assess, prevent, and manage pain, both spontaneous awakening trials and spontaneous breathing trials, the choice of sedation, assess for delirium, early mobility and exercise, and the family engagement. So these are the basic components of ABCDEF bundle. Now it has been extended further. This is done by the Scottish guidelines. They are talking about delirium 8. So they just don't talk about ABCDEF, but they are talking about post-delirium care also. So they are just talking about identifying and treating the distress, preventing complication, communication with the patient, and further rehabilitation. So they start from a different level, and they focus on the other parameters also, mainly focusing on the post-delirium care. However, the ABCDEF bundle has now been extended, that we are talking about gaining insight into the patient's need, that is a G, and holistic and personalized care, and using all this understanding in ICU designing and refinement. So a lot of work is going on in the direction, and what we need to now understand, the whole design of ICUs is changing, that now beds are placed close to the wall where the patient can overlook outside garden and everything. You have more spacious ICU rooms rather than cramped ICU rooms, and patient can directly look outside to the greenery. So this is how the ICU setups are being now changed across the globe. And in future, what we are going to have is, it's not just that we are going to see a green garden in the ICUs by side, but there will be a television screen over the head of the patient. There are a lot of the gaming consoles will be there, which can be used to prevent delirium in patients who are in the ICUs, or to manage delirium. And so one of these new concept which is coming is this Vital Mind by the Philips company, which has developed the combination. Like, this is basically a television screen. So whatever you want to project here, you can project. You want to have a green sky, blue sky, or you want to, patient wants to see a scenery here, anything that can be put, so that you can improve the patient's orientation and maybe make his experience better in ICU. So the nursing staff can provide this and can use this to also utilize the patient's, improve the patient's circadian rhythm properly. And this program stimulates the natural progression of daylight using the spectrum of glare-free white light, and the light conditions can be personalized for people. So this is what is going to come in, maybe not next 4 or 5 years, but I expect that in India also we are going to see this in next about a decade or so. Then in terms of evaluating the so-called non-pharmacological measures, there are multiple meta-analyses, but I'll just like to quote one of the recent one, that which suggests that use of multi-component intervention, as we have seen HELP program or ABCDEF bundle or more than that, is effective in reducing the incidence of delirium. So this is what is now very clearly stated. So we need to understand the non-pharmacological measures play an important role in the management of delirium. Again, other things which have been evaluated are something like bright light, which is not with much of evidence at this moment. So we have stopped that much of the research is not emerging. Now, in the patients of surgery, we are now trying to understand how we can prevent delirium, the post-operative delirium, because we have failed in evaluating the so-called anesthesia and other things. So what we have now, people are talking about evaluating the cognitive function at the baseline and evaluate the other risk factors, monitor for the MMSE and MOCA. And if there's reduction in the 2 points, maybe you need to screen the patient for delirium. And people are now developing a lot of video games so that you can train the person or engage the person effectively, cognitively, make him more aware, so that he is more cognitively active before the surgery, so that the risk of delirium reduces. And in the same direction, we have now understood that delirium is associated with higher risk of dementia. So this is more common in patients of surgery. And earlier, we are looking into this, and now we have a very clear relationship between delirium and dementia. What are the different common so-called risk factors and how they contribute to each other, how delirium increases the risk of dementia, and how patients of dementia at a higher risk of delirium. So in the context of the surgical patients, earlier there was a concept called post-operative cognitive decline, POCD. Now, but it has been revised, and now we are now understanding that post-operative delirium is associated with the neurocognitive deficits, and gradually it is leading to development of NCDs or the so-called major neurocognitive disorders. So the whole spectrum is now changing. So the whole aim is to reduce this so-called, so assessing the people at the earliest, preventing the post-operative delirium, and in preventing dementia in future. And here we are developing a newer concept called prehabilitation. So basically whatever the cognitive reserve or reserve in the physiological reserve patient has, we make that more robust to handle the stress of surgery and other things which are going to come in. So here we are again evaluating a lot of neuroinflammatory and endothelial dysfunction, neurotransmitters. So we are targeting different levels, and let's see where we are going to reach in future. So the basic thing now starts in a surgical ward is preoperative assessment of cognition and tailoring for delirium education to the patient and the family members, targeting for light anesthesia, pain management, and health programs and other things will come in. And at the time of discharge, you're going to assess again for the all these aspects and delirium, and depending on the cognitive status, referring the patient to the earliest to the concerned specialist. In terms of pharmacological management, in general, psychiatrists have believed that antipsychotics are the mainstay of treatment, haloperidol being most commonly recommended drugs. Low dose of other antipsychotics may also has been tried, but in general, the consensus is that we need to use lower doses of antipsychotic. We need to start low and titrate. However, the recent meta-analysis which have been emerging, what do they suggest? So this is a systematic review and meta-analysis of 108 RCTs, which suggests that in terms of treatment, quetiapine, morphine, and dexmedetomidine were effective in the ICU patients with delirium. But the strength of evidence is very, very low for quetiapine. Other antipsychotics does not figure. And in terms of prevention, dexmedetomidine and risperidone, both have high strength of evidence. They reduce the significant incidence of delirium in ICU surgical patients, and while the Remiltion reduces the incidence of delirium in the ICU medical patient. So this is something which is emerging, but despite efficacy, the dexmedetomidine and risperidone are associated with high risk of dropout because of the side effects. And haloperidol and other antipsychotics, except for quetiapine and risperidone, showed no benefit. None of the agents showed benefit in the non-ICU patients. So what the authors concluded, that dexmedetomidine may be the drug of choice for both treating and preventive delirium in ICU and the post-surgical patients, and current evidence do not support the routine use of antipsychotics in patients of delirium. If at all you want to use, you need to have proper indications for that. And for medical patient, oral Remiltion may be useful. So in terms of antipsychotic, other studies have also concluded similarly that no benefit of antipsychotics in prevention of delirium. And some of the studies, because ketamine is one of the common drugs which is used in anesthesia practice and psychiatry practice, that has been evaluated for prevention of delirium, but unfortunately nothing has come out. Our center was also part of this study. Our anesthesia team was part of this study, but the results were negative. So how to go about pharmacotherapy? Always weigh the benefits and the risk of using antipsychotics, and antipsychotics should be started in liaison with the patient's family caregivers or the primary treating team. And before starting antipsychotic baseline, ECG is a must, and QTC interval needs to be monitored. And we need to clearly document the indication for starting antipsychotic, use the lowest effective dose, gradually titrate, and monitor the symptoms of delirium and the side effects. And in general, psychotropics, the antipsychotics are not recommended for hypoactive delirium. So just few words, 2 minutes more. Melatonin and remiltion has evolved significantly over the period, especially during the COVID times, because they play an important role in the sleep, and sleep hypothesis has been there for delirium for long. But the role of melatonin has emerged because it has many other positive properties in the so-called, basically takes care of the it has antioxidative properties and so on, anti-inflammatory properties. So all this makes it that it is so-called associated with what we try to understand the delirium hypothesis. So that is where it is becoming a popular drug. But whatever the data we have at present, it has been found to be effective in prevention of delirium, but not much data on the management of delirium. So we do not have sufficient data set to make that conclusion. So this is possibly one of the last final slide. So how we can improve delirium care. So how we can make our hospitals friendly, delirium friendly. So staff should be aware that delirium occurs in 1 in 8 of their patients. Staff should have basic knowledge of delirium. Delirium screening should be practiced routinely. Information should be given to the patient and the families. The hospital should have delirium pathways, and basic delirium preventive measures should be in place. And environmental factors like orientation information, signages should be there for the patient and the family members. The family members should be made aware, and there should be experts to manage delirium in every hospital. So finally, concluding, research in the area of delirium has progressed steadily in the last 1 decade or so. Many new assessment instruments have been developed to assess delirium and other different aspects of delirium. Management main focus has been on the non-pharmacological measures. Pharmacological measures have not been found to be much of benefit. Relationship of delirium and dementia is understood in a much better way now, and there is whole focus on prevention rather than allowing it to happen and then trying to manage. Thank you.
That was an excellent presentation.
Yes. I think Vinay sir has joined.
Yes.
Dr. Vinay Kumar, sir, you want to say something because he wanted to join earlier. Sir, Dr. Vinay Kumar, it's over to you for your remarks.
I was listening entire presentation. I was very much here. Okay.
Yes.
Visible?
Yes.
Yes, sir. Visible, sir.
I was sitting like a humble student, listening to Professor Sandeep Grover, one of the experts in this field. Delirium, and our postgraduate students must have enjoyed the whole session. So with these 2 words, I congratulate Publication Committee for continuing this effort, and my gratitude to Dr. Sandeep Grover for sparing time for our students, our student members. Thank you.
Thank you, sir.
Over to Anil.
Can we have the questions from the chat box? Because we have 3 prizes for the best questions. So, Dr. Sujit, you can read out the questions to the and audience.
I
was trying.
No, I have posted the questions in the chat box. You can look at that. I have posted the questions.
Okay. So, Shazi sir, would you like to read out the first question? Shazi sir? Is it visible to you, sir?
Yeah. In the recent webinar, it was said that in India, there are no psychologists to give CBT. Hence, we give drugs as first line for OCD. Similarly, in India, as we cannot much alter ICU ambience, whether we will be forced to rely on. I think
Okay.
Obviously, this has to be answered in detail. CBT, or I think psychosocial interventions
For delirium.
for delirium.
Yeah.
Over to you, Sandeep.
So basically what we need to understand that management of delirium does not require everybody to be a specialist to carry out the non-pharmacological measures. You can just make the family members learn or basically inform them what is to be done. Basic, small, simple instruction like frequently orienting the patient, managing the noise around that, how to speak to the patient, how what is to be done when patient is getting confused or getting the watch from the home or the familiar things from the home. This do not require a lot of expertise. If you know the basic principle and if you're able to convey to the patient, family members and the carers, lot of the issues are taken care. Here, let's not compare it with CBT or BT, which requires some, or I'll say that a lot of expertise to carry out. Here, it's not that kind of a thing. So let's not compare OCD with delirium. And with regard to the ICU environment, I think we as psychiatrists, possibly none of us or most of us don't actually go to the ICUs. If you go to the ICUs across the country have changed a lot. We think about our residency days. Those are not the days now. The ICUs are very, very different. Yeah.
I think I must add here that non-pharmacological treatments are mandatory in delirium, and that forms the first line. And as was highlighted by Grover, this is something which you should train the staff, non-specialists, very simple interventions. I think that's it. So there is no scope for specialization there. Next one is what?
It's about children,
Yes,
delirium in children. Yeah.
Yeah, delirium, as I've already highlighted, delirium occurs in all age group. So it is nothing to do with adult or any particular group. It occurs in all age group, and now it has been recorded in patients of all pediatric, or let's say that is where the earliest, the lowest age which I have actually encountered delirium is about the age of 4 years. So we have seen delirium in all age groups. So there is no age bar.
Yes.
I think that's a very important point. Maybe if someone has persistent delirium and is very young or a child, then one should seriously consider a viral infection. CNS.
So, yeah, next question again posted says, asks about the maximum possible dose of haloperidol if the patient is not settling. So your take on that?
Yeah, the haloperidol dose which we normally end up using is about that you usually go on titrating very, very slowly. Usually patient respond by 5 milligrams. That's what the maximum which is usually recommended. But please understand that it's not just the haloperidol which is going to take care until you don't manage the primary cause. So primary cause has to be managed along with giving haloperidol. That's where the whole mistakes happen, that people just focus on giving antipsychotic and not address the primary cause of delirium. Until you don't address that, delirium is not going to settle down. So that is where we need to keep that in mind.
Role of benzodiazepines in delirium.
Yeah. So the basic role of the benzodiazepine, it is said that benzodiazepine only has a role when we are using it in patients who have alcohol withdrawal delirium. That's where the role of benzodiazepine has been said, and benzodiazepine has been actually shown to worsen delirium. So, but in certain situations, the benzodiazepine are also considered to be the second line management for delirium when you cannot use antipsychotic. Fortunately, now because we have melatonin in hand, so you can always try, like if you cannot use antipsychotic, use melatonin or Remiltion. If that does not work, delirium in delirium, then using benzodiazepine may be one of the last choices, but it is a primary drug to be used in patient with alcohol withdrawal delirium.
So there is another question. How do we use non-pharmacological measures in hyperactive delirium where patient is so agitated to cooperate?
Okay. Yeah. What we need to understand that hyperactivity in other things will at times persist. So you need to basically try to understand that when patient is not in a state that you can communicate or you can address that, then you can always try to use the measures which can be applicable. For example, patient is getting agitated because of noise around in the ward, too much of lighting in the ward. So you can reduce the noise. That is part of the non-pharmacological measures. Agitation is leading to dehydration. You need to address the dehydration part of it. Agitation may be due to sensory deprivation. So give the hearing aid or spectacle. That may itself actually reduce the agitation. So you need to understand when the agitation is there, that is where you need to understand agitation is not that it is occurring de novo. There may be other risk factors or the etiology which are contributing to delirium, and all those managing them is part of the non-pharmacological bundle.
Right.
I think that's a very important point, that anything which is not pharmacological, it's not necessarily psychological. It's environmental modification also. Thank you.
There is another question by, it says that in delirium with catatonic features, do we treat the delirium or the catatonia or both? What should be the treatment modality? Should ECT work to improve both?
Yeah. So when we talk about delirium and catatonia, when we need to understand, have this understanding that all patients of catatonia may go into develop delirium. So if somebody has developed catatonic symptoms before the delirium symptoms, you need to understand that your primary line of management should be in the line of managing a patient with catatonia. Whereas if the catatonic symptoms have followed the onset of delirium, the primary line of management should be in the line of managing delirium. So you need to, that is where it becomes important that you look at the chronology in which the symptoms are evolving and then take a call how you want to go about management. So if somebody has catatonia which precedes the onset of delirium, the management of catatonia should go in line of catatonia as you are managing. You can do the lorazepam challenge test. You can go for ECT. You can use underlying the psychiatric disorders or the medical disorders.
Okay. Shazi sir?
Yeah, I think there are more questions. Why is the course fluctuating? And why is this more at night symptoms?
Okay. Basically, night symptoms and the fluctuating course are because of the disruption of the circadian rhythm. So that is where we need to understand that sleep physiology is disturbed. So that is the primary reason why we see that the whole melatonin secretion and everything gets hampered in patients with delirium. The fluctuating course, again, is influenced by the so-called neuroinflammation, the oxidative stress and other things which keeps on happening. The simple corollary, which again I always tell my patient, the caregivers or the family members. Somebody has a heart failure, that does not mean that his heart is always at a particular rhythm or his respiratory rate is not at a particular rhythm. It will fluctuate. So it depends on how much the symptoms are getting controlled, how much the body is able to fight things in between. So understand that corollary, you'll be able to understand the fluctuation.
How to distinguish between hypoactive delirium and non-convulsive status?
Yeah.
And then pharmacological management for hypoactive.
Okay. As I said that at present, we do not have much evidence for pharmacological management of hypoactive delirium in terms of using antipsychotics. However, some of the recent trials have evaluated antipsychotics and they are saying that antipsychotics may be of some use, but again, not very convincing like data coming from meta-analysis. So let's not jump into using antipsychotics for management of hypoactive delirium. Now, hypoactive delirium versus non-convulsive status. Again, there EEG may be required to investigate, to diagnose the condition. So in that, when you are doubtful, you need to investigate further to make a diagnosis or conclusion rather than treating empirically.
Would you also think that non-convulsive status may be much more common among younger people than older people? Would
yes,
that be...
yeah, I agree. But in terms of making a diagnosis, just age, I will not take this just as a cutoff. But yeah.
So if there is inattention in delirium, how does we expect the patient to remember the experience possible? So essentially about dysfunction of memory during the course of delirium and PTSD later on.
Yeah. This is where we need to understand that somebody has inattention does not mean that he cannot remember the experience. The experience are very well remembered by a subgroup of patients, and they go on to develop PTSD. That is what we are now showing very clearly. So let's not presume that the whole experience of delirium means it is a blank slate once you improve from delirium. It's not a blank slate. As for example, if you talk to any patient with mania, after he has recovered, he'll be hesitant to talk about his experience of mania because he knows he have done a lot of foolish things in his mania. But once you probe and try to understand, he is also very distressed about his whole manic behavior. So similarly, in the delirium also, patients do remember their visual hallucinations, do remember their delusions, do remember their agitation, the tactile hallucination, everything. And once you try to talk to them, they will tell that they often get flashbacks about this and they have a lot of distress associated with this.
This is about quetiapine, anticholinergic, or generally about anticholinergic side effect or antipsychotics with anticholinergic action. Some of them are effective. How do you explain that?
Yes. So again, we need to understand that it is basically, when we talk about a particular antipsychotic is effective, whether it is treating delirium or it is just leading to sedation are two different things. So we need to understand that somebody who receives quetiapine may start sleeping, and because of the sleep, their circadian rhythm is getting normalized. So you are not particularly targeting the pathology, which is in terms of anticholinergic and the dopaminergic pathway. Here we are basically targeting more to do with the sleep pathway rather than the dopaminergic and the anticholinergic property. So the balance of that, although you are giving an anticholinergic drug, but the other pathway is being taken care of. So although the upper path, if you remember the whole hypothesis there, the circadian rhythm hypothesis is much above. So if you target that, then the lower neurotransmitter hypothesis will also get corrected.
I think we have covered all the questions.
Yeah.
Right.
I have posted whatever all I could get. So you can
yes.
Anything is left out.
Yeah. We have there are certain repetitions, but I think we have covered all the questions. Yes.
Yeah.
Anil, I think that's fine with the questions.
Yes. So any last comments from the chairpersons?
Maybe I will be permitted to say, I think if I happen to have attend a consultation, I make it a point to not only educate the relatives, but also the nursing staff, and then keep a hotline open with them. So it's not a one-time affair. You go to intensive care unit, diagnose delirium, make an advice. Then you put the duty resident available and keep that resident well informed about this case. And most of the time I've done this, that is, I do it myself so that people can see what I am doing. Because I believe that lots of the time, a lesser experienced person might do too many things. Whereas I want to show that by comprehending, understanding, and resisting the urge to act impulsively as a therapist or a physician sometimes helps to bring in some calmness into the ICU. And I think that's very important. I always try to remain extremely calm. And in the discussion with the consultants from the other side, as well as caregivers, you have to restore calmness into the ICU. I think that's very important.
Yeah, in fact, what I feel, I mean, agree with Shazi sir. In fact, I feel that, the atmosphere of ICUs till date in the country, especially in some of these small time setups, it is too cramped and too intimidating. And many of it had come up, as Dr. Grover was talking about PTSD, many of these experiences have come up and has become quite prevalent and talked about after the COVID times, because in the COVID times, many people were subjected to the fearful experience of being in ICU, and especially the COVID ICUs, and they have come back with major traumas. So basically, as long as we don't address the issue, the intimidating atmosphere, it is very difficult. And I think the change will come only with if people adopt the policies that have been discussed. I mean, rather than a knee-jerk reaction to sedate the person while both his hands and feet are tied. So again, the person somehow wakes up and finds that he cannot move his hands and legs. So unless that attitude changes, which unfortunately psychiatrists can try and make some change, I think the prevalence of delirium, it will not be so easy to counter. I mean, that would be my parting comments as a chairperson. A very, very well presented and updated presentation. I mean, we have definitely, and I think the students have definitely been enriched by it.
Thanks, Sandeep, for
Thank you,
the
sir.
latest information.
Yes. Yeah, thank you, sir. Thank you.
Very
Everyone.
useful.
Yeah.
Any last comments from Dr. Deepayan?
No, sir, I was listening all the answers because I think if we give more time, there will be more and more questions and sir need to answer for the whole night, because delirium is such a condition that it is very much confusing, and we need to encounter in all the situations every day a few cases. So there will be lots more questions. So, but we need to stop at any point. So that is the thing that we have come now. And at last, I just want to thank Sandeep Grover sir again, that the presentation was very much informative and many new things, actually, the ways of classification and the ways of treatment and the role of melatonin we came to know. And I think it will be very much helpful for us in our clinical practice and for the student also for their future. Thank you, sir, from my side.
Thank you. Thank you.
Dr. Anil, I think this will be available, the recording will be available in for the others also, right?
We will soon share it on YouTube. So people who have missed it or want to watch it again can watch it on YouTube.
Yeah.
So I think that's it. So comes to my job. So firstly, Dr. Sandeep Grover, it's been a very awesome and excellent presentation. I thank you once again for accepting our invitation and presenting this very important topic. I'm sure the students would have grown, their knowledge would have grown by listening to Dr. Grover. He is one of the best speakers for this topic, and I'm sure all of us have been enlightened. The slides were very good, and the involvement can be noticed by the number of questions we received from the audience. So we roughly received more than 20 questions. I thank our chairperson's senior psychiatrist, Dr. Shaji, for taking time in between his busy family schedules. And Dr. Sujit, it's been wonderful having you here. I thank our publication committee members for giving me all the support. And definitely the thanks goes to the audience for making it a grand success. We had roughly about 160 plus audience, and many would listen to it subsequently on YouTube. And we look forward to your participation in future programs on recent advances. So we call it a day. I thank our speaker once again. I thank the host, and good night all.
Bye-bye.
Good night. Bye. Bye. Thank you.
Good night, sir. Good night, sir.
The students, audience winners will be circulated in the next flyer. So people who have asked questions, the best 3 questions will be awarded 3 books on recent advances. The names will be circulated in the next flyer. Thank you. Good night.
Thank you. Good night.